Welcome to the
Yeah.
Functionally Enlightened podcast. I'm your host, Dr. Sharon Surita, and today we're thrilled to have a special guest who is a true pioneer in women's health, Dr. Jessica Drummond. Dr. Drummond is a founder and CEO of the Integrative Women's Health Institute and the Outsmart Endo Health Coaching Program, and she created the Women's Health Coaching Certificate. With 2 decades of clinical experience as a licensed physical therapist, clinical nutritionist, and board certified health coach, Dr. Drummond is dedicated to empowering individuals struggling with women's health and pelvic health concerns. Her unique integrative approach has made her a sought after international speaker on topics including integrative pelvic pain management, natural fertility options, optimal hormone health, menopause, and female athlete nutrition. Educated at the University of Virginia, Emory University, Duke Integrative Medicine, and Maryland University of Integrative Health, Dr. Drummond is passionate about educating clinicians and wellness professionals on safely using integrative tools to transform women's and pelvic health care. So, Dr. Drummond, I'm so excited to have you on the show. Can you start off by telling us a little bit about your background and what led you to specialize in women's health?
Yes, thank you so much for that kind introduction. I started my career back in 1999 as a physical therapist. I was always an athlete, so I thought I would be doing sports medicine. And I did start in orthopedics, and I really fell in love with working with clients who were dealing with women's and pelvic health related conditions that were orthopedic. So if you think about physical therapy, you have orthopedic conditions post breast cancer surgery or pre breast cancer surgery for that matter, or pre and post natal, postpartum, in perimenopause. For example, frozen shoulder is a very common symptom of perimenopause. So I began to subspecialize in these women's health related orthopedic conditions and then learned more and more and began to specialize in pelvic health concerns, things like pelvic pain, endometriosis, painful bladder syndrome, vulvodynia, and also things like prolapse and bladder incontinence, and all of the issues that came with pregnancy and postpartum. I worked for about off and on for about 10 years at a women's specialty hospital where we delivered approximately one baby every hour, 24 hours a day, all year. It was about 10,000 babies a year. So we had a lot of women in the hospital on high risk bed rest. We had a lot of women with chronic pelvic pain, fertility, perinatal, postpartum issues. So I spent a lot of time doing that. And I realized kind of, in the early 2000s, around 2005, 2006, that our physical therapy tools were not enough for the complex pelvic pain syndromes that we were dealing with, particularly things like endometriosis. And so I went back to school and I got a doctorate in clinical nutrition. But before that, we just didn't have the tools that we have now. First of all, the endometriosis surgeries were not as good. There was a large focus on pain management, but utilizing opioids primarily. So a lot of my clients were addicted to opioids or they had implanted stimulators, neural stimulators, and none of these tools worked very well. But the combination over the last 10 to 15 years of improvements in endometriosis surgical techniques, in using functional nutrition to optimize digestive health and pain management. We have a lot more knowledge about pain science and its integration with nervous system health, trauma, and other sort of early stage risk factors, hormonal health, and our techniques in pelvic rehab have also advanced. We now have a much better suite of tools to support endometriosis and other chronic pelvic pain conditions and help people fully resolve them. That said, our environment has gotten more complicated in the last 15 years. So we have much more exposure to environmental estrogenic chemicals, things like microplastics. Glyphosate didn't even exist in the 1990s. And now it's essentially ubiquitous within our food. And so that impacts digestive health, gut microbiome health. We have a heavier exposure load of chronic viruses and other infectious syndromes. that is being significantly exacerbated by COVID and the long COVID crisis. So, on one hand, a lot of what we do to address chronic pelvic pain conditions and autoimmune like conditions such as endometriosis and vulvodynia are improved a lot with our tools and ability to handle them, but they're also being exacerbated by the environment that we currently live in. And we used to call the common comorbidities of endometriosis were painful bladder syndrome and vulvar pain. We have that, and we have this chronic post-viral situation, especially for women in their 30s to 50s. That's extremely common. It's up to 40% of people who've had more than one COVID infection. And so they have also things like histamine issues and dysautonomia and hypermobility syndromes, which may have been a part of the pre-existing syndrome of endometriosis, which is at least in part an autoimmune inflammatory condition, but it's being exacerbated by this current environment of heavier environmental toxin loads and heavier pathogen loads, viruses and bacterias and such.
So it goes back to the chicken and the egg. Which one came first in terms of like the autoinflammatory conditions? When in my community, we are people who have undergone mesh implants or any other type of implants for that matter. But there's this Asia syndrome that is akin to autoimmune disorders. But
Mhm.
in what you were just mentioning about being exposed to all these environmental toxins nowadays, it's the question is, are we experiencing this overload because we have the autoimmunity, or is it the other way around? Are we developing these other conditions because of the toxin overload?
Right. Is the autoimmunity essentially being caused or exacerbated by the exposures, or is the autoimmune condition already there, sort of it was triggered from sort of a genetic vulnerability, for example, and then made worse by these exposures? I think the reality is it's both. Many women have sort of a vulnerability, whether it's due to genetics, stressors, the ability to be resilient to these stressors. But also, we know, for example, that COVID and other viruses cause lack of immune resilience, right? It causes lowered levels of T cells, less effective T cells. And so I definitely think we have a chicken and egg kind of situation, that if you have any of these vulnerabilities and then you're trying to live in this more toxic environment, these things play into each other. So I don't think it's ever that it's just one thing causing these challenges. And also, women in midlife and the perimenopausal age range are carrying a lot of day-to-day, just mental load and emotional stressors. They may have had other just injuries along the way. Maybe they had a concussion, or they had a sinus infection, or they had a postpartum injury, something like a prolapse, or a spine injury or something like that. So I think we need to always look individually, and then especially when we sort of started getting into circular challenges, like where one thing causes another thing, and that makes the first thing worse, and we don't really know where it began. The way we approach things at the Integrative Women's Health Institute is our motto, if you will, is don't chase symptoms, optimize systems. Because it is hard to tell in many cases, and every case is so different, what is the underlying root cause. And so we're just starting to strip away and make each and every physiologic system stronger and more resilient over time. And sometimes that takes a lot of rest and reducing these various kinds of stressors, whether they're mental load stressors, toxin exposure stressors, emotional stressors, lack of sleep, financial stressors. And that's not always within the client's control, but still starting to make a plan in those different directions for taking away those stressors can be really, really helpful.
Absolutely. Yeah. And so I know that your approach includes a 7-step sort of coaching model. Can you walk us through what your 7-step process is?
Yeah. So even when I'm working sort of in a clinical way, trying to help a person heal from, let's say, endometriosis or transition through the perimenopausal phase without so many symptoms, hopefully feeling really good, maybe even feeling really even better through the perimenopause to menopause transition, I always lead with a coaching model. So, what health coaching is actually a communication strategy for centering the client. And then all of the healthcare team really works for that client, right? It's not a model of like, you're doing this wrong, you're doing that wrong, you better take this checklist of supplements and medications and do these exercises. And that's a more patriarchal model, right? So instead, we start with helping everybody regulate their nervous system. So I want the design of how I talk, my telehealth experience, my client's experience in the, if someone has a health coaching practice that's in person, like what does the room feel like? What is the music? What are the noises and the scents? And just helping create an environment where your client can feel very safe and at rest. And so, as we create that environment, that's when we begin to help them heal. Because even though creating that environment isn't a fully complete treatment strategy, it does set the nervous and immune and digestive systems and the hormone systems to some extent in a more healing orientation. So the body's own natural healing strategies can kick in, or at least we stop the bleeding, right? We stop the chronic inflammation from being driven by the nervous system's response to stress. So most of my clients are either living in kind of a freeze state or a fight or flight state, or they just kind of hop back between the two. They're not living in this state of like, oh, I'm safe, I'm at peace, I'm well supported, everything is going to be fine. I have this all under control. I have all the support that I need. That's a very rare experience in this day and age. So, starting with that, and then both modeling it and teaching our clients the tools to help them get there more commonly or more often is really important, step one. And so for my students, we do a lot of education of health and wellness professionals. They have to learn this and practice this first because they're the mirror, they're the model. And if they're running between 17 patients a day, it's very hard for them to maintain a regulated nervous system. So setting up our work environments is really important. Step two is helping our clients to get very clear on what their vision of healing is. We think of healing kind of generally as a dichotomy. You're either sick or you're healthy. But what does that really mean? There is really more of a continuum. Someone could have a chronic illness and consider themselves pretty healthy. They're doing well. They're well managed. They're very active. Someone could be an Olympic level athlete or a professional, I don't know, whatever, marathoner, CrossFitter, and have mental health challenges or have immune suppression that you can't see. They might have amazing muscles, but an amazing endurance, but they may have a deeper issue. They may have, early stage heart failure, like who knows? And so I think we need to be thinking about helping each person define what health means for them, how they feel, what they can do. It's not just about lab numbers, although those are also things we can integrate. Maybe someone has an elevated hemoglobin A1C and they want to get that to a certain level. That's a part of their vision for health. But also why? Like, why do they want all this metabolic health? Is it so they can travel more, so they can be more present? They're neurologically healthy and attentive, and they can be more present with their partner or their family or at their job. So I like to think of health as a continuum. On the one side is death, but even death, though, people who are transitioning into death can do it in healthier or less healthy ways. Some people are very well supportive and they feel like they've lived a full life, and then others have much more traumatic experiences. So every stage of this continuum is a continuum of healthy or sick. It's very it's just not true that some people are healthy and some people are sick. Everyone is sort of along this continuum. So defining what that means, what your client's key values are, and what are some of the goals that can show us that we're moving in that direction. And I tell my clients, especially those with chronic illness or who are in that 10 or 15 years of perimenopause to menopause transition, this is not an upward straight line of healing. It's not quick. It's not linear. It's an upward spiral of healing where over time we get more and more healthy, but day by day, it can be a little messy looking. And then in step 3, we collect data. And I like to collect 3 types of data. One is the client story. That is the most important piece of data because very often clients will really tell you what the next steps are, what they really need, what actually is going on, if we give them enough time to safely and fully share their story. Conventional medical practice allows for about 7 seconds before the client is interrupted. I like to have a minimum of 10 minutes of the client speaking and sharing and feeling comfortable. And we also may uncover different parts of the story that the client either forgot or wasn't comfortable enough to share over the next few months to years. So 1 is the client story. 2 is lab testing. That could be all kinds of different things from gut microbiome to nutrient absorption to genetic testing, whatever. And then the 3rd is wearable data. We have all these great direct consumer things like Oura rings and Garmin watches and Whoops and Apple watches. And those are great tools. If you compare them to themselves, it's okay if they're not perfectly accurate. They give us a lot of good general information about stress response, sleep quality. And those are some really valuable insights, even just like daily activity. Because someone might be exercising an hour a day, but they sit the whole rest of the time. So whereas someone who maybe doesn't do that hour hard workout every day, but they walk on a little treadmill or they walk around their block every couple hours, that can really add up and is sometimes more beneficial even than a hard workout every day.
Can I stop
And
you right
then,
there real quick?
yeah.
On that piece with the wearable technology, do you have a favorite for tracking sort of the heart rate variability and maybe the progress over time so that people with less mobility have something to definitively see?
Go for. Yeah. My favorite that I use, so I use an Oura ring myself just because I think it's more comfortable. So there's 2 favorites. I like the Oura ring because it doesn't beep or there's no like face to it that gives you any information. You have to plug it in for you to even know what's going on. So it's very passive. And I like that because it's just non-intrusive. I just download the data once a day. I look at it on my phone, make sure we're kind of on track, and that's about it. For my clients, I normally use a tool called the Garmin Vivo Smart 4. It's a thin watch. I have one actually right here. It looks like this. They have different colors. So there is a little face to it. And so it will give you like steps goals and, stair climbing goals and stuff, which is okay when the downside is the bias of the Garmin is towards activity, which can be a good thing. But a lot of my clients actually need to rest more. And the bias of the Oura is more towards rest and sleep. But what I do like about the Garmin more than the Oura is that there is a very passive tracking, and the display on the app on the phone is very obvious for clients about when they're stressed versus when they're in recovery all through the day. Whereas the Oura basically tracks your resting heart rate your heart rate variability at night while you're asleep. It doesn't really track stress as well. It's just started doing it, but it doesn't track stress as obviously during the day. And this is where my clients can make changes, right? They can see that, this work meeting is stressing them, or being with these people is stressing them, or the moment they wake up and put their feet on the floor, their thoughts are stressing them. Like, it becomes really obvious because it's like orange or blue. Orange is not good. Blue is in that recovery state. So we talked about in step 1, we want our clients to be in that nice nourishing, healing, rest and digest, calm aliveness state. And they're only in it when the watch is not orange. And very commonly, I have clients with endometriosis for 15, 20 years who are like, oh, I'm not stressed. I feel fine. And all day, they're in the orange, or some of them even all night, they're in the orange. So it's a really obvious one that I think, and it's less expensive. It's easier. Well, they're both easy to get, but it's a less expensive tool. So that's where we begin.
Appreciate that. I know the Oura ring was something that I had my eyes on. I've been using more of the watches, but they do become an encumbrance even in sleep sometimes. So that's just for people who are highly sensitive. Maybe it actually is waking them up at night. Not so much having the notifications because we can silence those, but the actual just the physical object on our arms. So maybe the Oura ring is a great option for people like me.
Agree. And that's one of the reasons I like it the best. The Oura ring is great because it's also very passive, and it does have like a little red light on it now because it tracks your sleep, your overnight oxygen saturation, but I don't find it bothersome in any way. It's the least bothersome thing. I've slept with watches. It's more annoying than the ring. I really don't even notice it at this point.
I'm sorry to have interrupted. I know you were talking about I think step 3 we were on.
Right. So step 3 is those 3 pieces of data: story, labs, and wearable tracking data. Step 4 is then we make recommendations in the form of education. So when I think about how I was taught to practice as a physical therapist or a nutritionist, it's like the client comes in, you do the assessment, which is similar to step 3, and you get all the data and you do their exercise testing or their lab testing or whatever. And then you're like, okay, here's what I think you should do. In a coaching model, the difference is there are some obvious first couple steps, at least, and even later on, is if we take this step by step, where the client kind of already knows what to do. And you really empower that wisdom. You show them all the data, you help them understand it. Then sometimes, so for example, I had a client earlier this week who was struggling with some digestive issues post surgery, and she was a little worried about it. And I said, okay, well, let's make sure, let's double check with your medical team that there's nothing serious or sinister. And then we're going to look at what are the probable options. So then I can educate her on what are the likely things going on, given my knowledge. If I don't know everything about everything, I may help refer them to another practitioner who could give them more insights, or have them do a little of their own research, or often they have some of their own experience that they bring to the table. And so in this case, the client's issues were sort of coming down to like more of a dysautonomia or more of a food sensitivity. And we talked about how they would each show up, what that could feel like, what are some of the red flags for each issue. And she felt really, really clear kind of which one she thinks it is. And so we have this data, but the data, it's very rare in this nuanced practice where we're dealing with lots of things happening at the same time that you have like the lab markers tell you exactly what to do. They don't. They're useful insights, but they're not like going to be like, okay, this X says X, Y, and Z. Now you need to take this supplement stack. It's just not how this works. And so now with step 4, we're both using our clinical and our knowledgeable education, but we're centering the client and helping us co-create the plan. And then in step 5, we're actually writing it down as a plan, because it's one thing to give people like a checklist of stuff to do, drugs to take, supplements to take, exercises to do, what time to go to bed, which wearable to wear, yada, yada. But it's a whole other thing to actually integrate it into their daily schedule. When are you going to do this? Who's going to support making dinner if you're going to do your exercises? What time are you going to go to sleep? What support are you going to have around meal planning? What accountability are you going to have to get your walk in every day? All of these things that make it more likely that the client will visualize the potential obstacles to them actually implementing a plan that they helped to co-create. So they're more invested. And then in step 6, we make sure they have all the support they need to get that done. And they don't always, right? Like, look, I wish I had a whole other team of people like making my food for me and picking
Say
up
the
my
same.
kids, you know. But we start with what they have and make sure they're at least utilizing the resources that they have, because sometimes there are some things right under their noses that they're like, oh my gosh, I didn't realize that I could ask my kids to empty the dishwasher, or they just don't really think through the potential resources of support. So we have a schedule, we have the resources of support, and then step 7 is essentially that every session or every few months we reassess, where are we? And so this is a spiraling system. Like, where are we in context of, are we still on track towards our vision, towards our goal? Have we decided to change the vision or goals? Are things going better than expected? Are we stuck somewhere and we need some more support? And so that's our reassessment stage.
And you did mention a specific condition that we're seeing more diagnosed is dysautonomia as the overarching term, but we have like the orthostatic hypotension and mast cell activation, which is kind of all lumped together. And a lot of people who are experiencing, again, some type of implant illness have a lot of symptoms that kind of correlate with dysautonomia, and they do receive that diagnosis later on. Can you talk to us a little bit about the clients that you see and how they're expressing the similar kind of symptoms?
Absolutely. So dysautonomia is any kind of, and there are lots of different triggers of dysautonomia. Dysautonomia means that the autonomic nervous system, the nervous system that should be just doing things without you thinking about it, your heart beating at the right pace, your blood pressure shifting moment to moment, your salt balance shifting moment to moment, your temperature regulation, all of that should be automatic. But lots of things can trigger dysautonomia. It's a common vaccine injury. It's a common sequelae of COVID infection, whether or not you had a vaccine. Either way, you can have it from vaccine or from COVID, even if you've never had a vaccine. It can come from implants, whether it's things like bladder mesh or um, breast implants. It can come from autoimmune conditions, other bacterial and viral illnesses, post-viral syndromes, and probably some other things. There may be some genetic vulnerability related to things like hypermobility syndromes like Ehlers-Danlos. And then it absolutely goes hand in hand with mast cell activation syndromes or histamine challenges. And this is another little chicken or egg. I think generally something incites the immune system's intolerance, right? So that's what mast cell instability is. It's the activation of the immune system to things that it shouldn't activate against, or to abnormally to things that it should activate against. So it could be triggered by a virus, and it kind of gets stuck in overactivation. So the immune system should activate to a virus, but it's not activating in a coordinated fashion. It gets kind of stuck in overactivation. It should also be activating potentially towards things like meshes and other implants, but ideally we wouldn't want it to, right? But then there are other things it shouldn't be activating to, like foods, for example, or vaccines, for example. They should be designed so the immune system isn't overreacting to them, but it does want a little bit of an activity, and sometimes we don't get it right. And also it's not even sometimes we don't get it right, but sometimes the scientists that develop these vaccines get it right in general for the population, but not for everybody in the population. So some people are more vulnerable. So what then happens is some of these immune cells that release histamine and other inflammatory mediators are easily triggered. They're easily overactivated. And so there are a lot of tools we can now use to stabilize the mast cells, things like pycnogenol, things like quercetin, medications like ketotifen and cromolyn sodium. And what I like about doing that as a part of a dysautonomia picture is a lot of times people don't realize they also, if they don't have classic signs of this histamine activity, such as welts and skin rashes and stuff, but if they could be really mild. Like I was talking to someone earlier today, and she just had like a redness around her mouth. And that's a sign of that reactivity. She said that if she like scratches her skin, it immediately turns red. So she wasn't really aware of skin rashes, but she does have this like overreaction to maybe, other people might have it to bug bites or something like that. But another less common sign that I see more and more commonly is slow digestive motility. So it's hard to eat and you're sensitive to a lot of foods. Bladder burning is really common, urethral burning, vulvar burning, any kind of burning pain, actually. It could be joint pain, it could be vascular burning, but bladder and vulva are often common in the pelvic pain patients I see. And these histamine issues, we both have to kind of quench the histamine, and we can do that with foods that with diets that are high in these antihistamine nutrients. I don't like to use low histamine diets because I feel like anything very restrictive in this population just feels overwhelming and dysregulates the nervous system. But instead, we can think about what are the foods that are really good to help stabilize the situation. And that would be like a vegan onion soup. Onions are great. Apples, more foods made with apples, or green smoothies made with apples, things like that. So we have a lot of nutritional tools that we can use to stabilize mast cells. And then also we want to help optimize nervous system functioning. And one of the best tools to do this is to spend much less time on our phones. We have some good data to support that. Definitely on social media and like scrolling, that sort of thing. And a lot more time in nature. So that, and then there are some very practical things like wearing compression socks or leggings, or if there are like vulvar varicosities, even wearing compression like biker shorts, where using salt water in the morning, especially earlier in the day, drinking, hydrating with salt, heavy salt electrolytes, being careful in hotter temperatures. And when it comes to exercise, I find really the best kinds of exercise to help build more stability in the nervous system are either Pilates or swimming. Swimming, because the pressure of the water kind of helps maintain the pressure in the vascular system and in the capillaries and even in the lymph. Lymph management strategies are also key in this population. So swimming is better than upright exercise. And that's also why Pilates is really good. You can get resistance training, but you're in a kind of a parallel supine or prone position, front or back. And so you can be strength training, but in lying down or sitting, where there's less work on the autonomic nervous system to regulate blood pressure.
My clients, we like to use recumbent bike first off because of the mobility constraints. Again, they've been using, a lot of the clients I work with are severely hindered. So they use some type of rollator, sometimes they're in wheelchairs. Mm-hmm. So the recumbent bike is great if they can get mm-hmm. into a swimming pool also. But I think that as they develop their strength and return to strength training, that seems to be more beneficial in the long run towards like reducing the tachycardia episodes or syncope episodes I'm seeing. But it does take a very long time. And that's something that people aren't expecting. They think that, physical therapy, they'll be back in business in 3 months. And that's like a good time frame. But sometimes it can take years, especially if they've developed dysautonomias.
Absolutely. And I do think it is encouraging over time when that cardiac rate, that tachycardia, the heart rate starts to feel more stable, when the kind of dizziness feels more stable. But you're absolutely right. It can take a while, and it depends on where you're starting from and how stable you were before. You might be on a recombinant bike gently for 3-4 months. Then maybe you can progress to a rowing machine or even just walking in a pool if you don't have the upper body strength to swim. Lying down and doing very light resistance Pilates on a reformer. can be very, the other thing I like when it comes to strengthening people with dysautonomia, because again, dysautonomia and mast cell activation syndrome often go along with hypermobility syndromes. And so strength training can really help stabilize those hypermobile joints. So I like to do what's called closed chain exercise. And that means exercise where your feet or your hands are like touching something. They're on the floor. They're not kind of like out in space. So squats are a great example. But again, a lot of times people with dysautonomia can't do upright strength training. So we can do squats on a Pilates reformer, where they have their feet on a bar or a platform. So, but you're essentially laying down, and then you can layer on resistance until the system can tolerate that. Then you could start with upright, lighter exercise. The other thing that can be valuable is vibration plates, for like lymph drainage and balance training, but have to be careful because it depends on how resilient the autonomic nervous system is, because it does kind of shake up the brain and nervous system a little bit. The other thing I also like, which is another reason why I like Pilates, is any kind of trauma release exercise. And that's literally kind of when you get the joints shaking. You can put people in different positions to get the joints a little shakier, but a lot of times Pilates will do that anyway because people get in a position where they're a little bit weak. And that gives us, when they shake a little bit, just let them stay there for, a few minutes and notice if they have a lovely sense of calm afterwards.
You think that that would be something recommended to people who've had multiple pelvic operations? Is it something that's doable for them?
Yeah, I mean, we have to start really, really gently, right? We might just start lying down in a hook lying position where your knees are bent up and you're just rocking side to side, or you're doing a supported bridge. It really depends. We absolutely start very, very gently wherever people are.
Yeah. In my journey, I had hernia mesh implanted, but it was abdominal.
Mm.
It severely hindered every type of motion. So when I started physical therapy, it was more just based on posture alignment, which is absolutely necessary, but it didn't do anything to help me build strength. So I like that you have like a format to go to, or somewhere that people can actually look for this type of reformer Pilates to get started with, especially if they've been sedentary for so long. Now, I know I want to be respectful of your time, but I kind of wanted to touch on the role of nutrition and supplements, especially in the, let's say, the perimenopausal demographic. I'm still really looking into people who have gone through some autonomic nervous system dysfunction, and they're really struggling with the diet and the lifestyle and the nutrition piece.
Yeah, I think similarly to the exercise piece, we start where they are. Do they have a lot of trauma around food? Do they have disordered eating? From an autoimmune standpoint, the most evidence-based nutrition protocol, if you will, is a paleo diet. It's essentially meat, fish, eggs, and lots of vegetables, some fruit, nuts, seeds. You're eliminating grains, dairy, sugar. That's basically it. Because you're trying not to irritate the immune system, and grains and dairy are the most irritating. And some slightly more stringent versions of a paleo diet, you would not have also any beans or legumes. And that's just because these foods tend to kind of trigger that, immune response to things that it shouldn't be triggered to. But as the digestion gets healthier and healthier and healthier, my goal is always to expand. And in some cases, there's actually some benefit to temporarily starting with just meat. This is where a carnivore diet can come in. But again, I think of that more like a steroid shot. Like we don't do that for months and years. We might do that for 6 weeks or maybe 3 months. Same thing with a raw vegan diet. Depending on people's genetics, these relatively extreme diets can rest the system. There are people who do better with that sort of carnivore rest or even sort of intermittent fasting, or both. And then there are some people who do really well with raw vegan diets, which is another way to rest the system. Genetically, there's some variability in which one. Oftentimes people kind of know, like they're like, oh, I feel great on the vegan diet. I feel less good when I'm eating meat. And the opposite can be the case. Generally, there are some blood type correlations with certain genetic pictures that can help us start figuring out where. But if you don't know where to start with a Mediterranean Paleo food plan. Basically, we're just talking about eating real food, which, as we talked about in the beginning, is hard to do in the United States because pretty much all of our food has glyphosate in it and microplastics and all kinds of junk, PFAS, forever chemicals, PFAS. So I feel like the more important thing over my years of being a nutritionist, I used to try to really help people dial in the diet. Quite frankly, the diet right now, because our food is not very healthy, just in the way it's processed and grown, is that we look at it in every case as like, can this nourish me in some way? The colors, the smells, the taste, the people I'm eating with, what nutrients are in it. I try to look at all of the benefits of the food. And then if people are willing to explore taking certain things out, giving the immune system a rest for a little bit of time while we're really healing the digestive immune interface, because that's where about 80% of the immune system is. We're healing gut microbiome and the lining of the small intestine and the health of the gut acidity, and we're helping motility and all of those benefits of healthy digestion. Sometimes we can do a temporary, quote unquote, elimination diet as a therapeutic protocol. But generally, we're not wanting to have to be there forever. We're just wanting the highest quality foods, the most diversity we can get, because that's going to benefit the gut microbiome. Sometimes fasting is helpful for temporary periods of time, or intermittent fasting. But I really try to meet people with food has such a social significance that we have to think about that in context for people. Because, I've worked with clients who've been like, oh, well, I felt amazing after a 25-day fast. And then there are some people who I can't, by the way, that's not medical advice. Like, you don't just fast on your own. But, there's some merit to that in certain circumstances. And other people who do, they're like, I tried all the perfect diets. I did everything. And then finally, I just started eating like pizza and beer with my friends, and I felt so much better because there was they just took the pressure of the diet off their nervous system. So I think nutrition can be a very valuable food, but we really have to do that collaboration and step forward with our clients to see what meaning food holds for each individual. And then what sourcing of food do they have available to them? Like if someone lives on a biodynamic farm, that's a different story than someone who lives in a food desert,
I love that you capitalize on that and the individuality of everyone, because I've been through many, many different diets myself. And, I like to experiment with things before I work with particular client groups. And so I've gone from the medical medium protocols, where it's like pretty much vegan, zero fat. And then I've done carnivore, as you've mentioned. I've also done the Walls diet, the Walls protocol.
Mhm.
And what it was is for a lot of the people that I've seen with dysautonomia, with neurological symptoms, they seem to do a lot better with, let's say, staying in therapeutic ketosis. Is that something
Yeah.
that you've seen with that specific client group?
Yeah, and that makes a lot of sense with the data that we have on depression, on dementia. So, Kat Toop's work, Dale Bredesen's work on brain, even the old data we have on ketosis for seizures and seizure disorder. So, absolutely, I do think the brain prefers the more ketotic, more high fat paleo or moderate fat paleo, or all the way to carnivore, depending on the situation.
But that too would probably need to be in moderation. Like, I wonder what the long-term research is really going to show you 10, 20 years from now.
Well, and that's the thing. I sort of feel like what we want to build is a sense of metabolic flexibility, so that maybe someone stays in a more, low carb plan for 6 months, a year, 3 months, 18 months, something of this range. But the other thing we can't discount is that pretty much all of the longevity studies point to Mediterranean style diets, which are high in olive oil, high in nuts and seeds, high in locally grown vegetables, and those polyphenols, blueberries and beets. And, there's so much benefit to the polyphenols that, and also when we're talking about deep level healing, we're talking about pleasure, centering people's health goals. What does health look like to them? And sitting around a table, eating creative, nourishing local food is a key pleasure in life. And so I want to help my clients embrace that if that's meaningful to them. Some people just don't care. I mean, my mom, for example, like she could, we used to joke. There was like this one kind of random course I took where they were talking about breatharians, like people who basically don't eat. And I was like, that could be my mom. Like she's just uninterested in food. She eats, but only because like you have to. She just doesn't care one way or the other. My dad, who's Italian, like thinks about his every day in terms of what he's going to eat and what he ate before and what he's going to eat next. And so I think it really depends on how people view eating. Is it a very social, creative, loving experience? Is it a necessity? How do they feel about it? And that's a part of it too, because I think you're exactly right. I think clinically, physiologically, the brain clearly loves a lower carb experience. But how we do that, there are lots of different ways to do that.
Doesn't necessarily mean strictly carnivore, so I like that you approached it that way. Now, a couple of things before we end up. I know you have all of these coaching programs available to not just patients but also to practitioners. So how could
Mhm.
people reach out to you or learn more about what you have to offer?
Yes, our website is integrative women's health institute.com, and we have a number of free workshops and guides there that you can go to under free resources. We have a podcast. There's a link on the header to the podcast blog. We also we're pretty active on Instagram at Integrative Women's Health. And if you want to work with me directly, you can reach out to our team, support at integrativewomenshealthinstitute.com, or send at Integrative Women's Health on Instagram a direct message. And, myself and my colleagues do work individually with clients. And then we have a number of professional education programs, health coaching certification, and then subspecialty programs in perimenopause, menopause, longevity, endometriosis, and generalized functional nutrition, if this is all brand new to you.
Cool. We appreciate that. And we'll make sure to include it in their show notes. We'll have links to the website. And particularly, I probably want to include some narratives of the programs that you do offer. So I appreciate
Great.
it. And again, Dr. Drummond, thank you so much for your time. Thank you for sharing your wisdom and for giving us all hope for people who are still struggling with dysautonomias.
Absolutely. There is hope. I know it's frustrating. I've lived that experience myself, but you can recover and strengthen your nervous system resilience. So thanks for having me.
And thank you to our listeners. We'll see you on the next one. Take care.